Hello class, we are going to move on to the endocrine system here. The endocrine system is composed of many different glands in your body that work together to create a balance. And I like to kind of think of this as like a spider's web. They connect in many different ways, and so there's a huge balance component that comes into play with all of these. And when you're going through this system here, this endocrine system, I want you to remember that there's many different functions with each gland. So there are going to be many concepts that come into play. We just went over fluid and electrolytes, so that's going to be one of the concepts that is going to be affected when we look at some of these specific glands here. Another concept can be cellular regulation or immunity. And there are more concepts as well. And as we go through these slides, maybe you can think of some more concepts that have to do with this specific system here. So we'll go ahead and get started now. So let's take a look at the anatomy and physiology of the endocrine system. Here you can see all the organs and the glands that come into play. And remember that all of these communicate through hormones that are primarily controlled by the hypothalamus. The hypothalamus is the mastermind. It's kind of like the puppet master, if you will. It's a neuroendocrine gland that releases hormones that regulate the pituitary gland. Remember, there's the anterior and posterior pituitary gland. And these glands are responsible for many hormones that are released and then travel to the other glands here, like for example the adrenal gland, the gonads. So and all of these are controlled through a negative feedback mechanism. So if the hormones at the end of this connection are too high, then give a negative feedback mechanism to stop making that releasing hormone. And so we're going to talk about how if we have an excess or deficiency in some of these hormones being secreted, then that can lead to a lot of pathological conditions. So that's where we're going to go ahead and go to in this PowerPoint. When you assess patients who have endocrine issues, you want to start with, well, you know how we always start with history, and we review the systems, and then we ask the questions before we go into our physical assessment, right? Some of our questions for history should include family history, nutritional history, and their own history, their past medical history. Some of the review of system questions specifically for endocrine are any changes in energy levels. Because here we're not just looking at one specific gland, we're having general questions to kind of pinpoint which gland can the endocrine issue be coming from. Is it something from the adrenal gland? Is it something from the thyroid? Is it something from the gonads? We want to have like a general idea of what questions to ask, so we can start kind of narrowing down which gland this problem is coming from. So that's why we ask energy levels are being changed, any changes in the elimination patterns. So that can kind of tell you maybe their metabolism is changing. So that would kind of make me go focus on the thyroid gland, because the thyroid is responsible for controlling metabolism. Changes in sexual and reproductive function and physical features, that would kind of narrow you down to maybe the adrenal gland and also a gonad problem. After you ask these questions, your physical assessment, you want to start with general appearance. How do they look like? Is there a fat distribution? Is it symmetrical? How are their expressions? Do they have a dual or flat expression? Some of that could be from an adrenal gland issue, or assess their head, ears, eyes, nose, throat. How is the skeletal shape of their face? Do they have a prominent forehead or jaw? This could be a pituitary gland issue. How's their face? Is it round? Is it puffy? Do they have a exophthalmos? How are their skin, hair, and nails? Is it evenly distributed? Do they are their nails thick and brittle? This could be an adrenal issue. And then because a lot of these glands they involve a lot of changes, some of these patients might have a lot of psychosocial issues. So pay attention to any changes in their behavior or personality. How are they coping with these changes? Do they have a support system that they can lean on, or that they can help them with these changes? How do they perceive themselves? Do they have any depression? And also, are they ready to learn? So there are a lot of things here that might not make sense to you at this moment, but I suggest once you complete the whole endocrine PowerPoints to come back to this slide, and because now that you have all the information, all the pieces, this the way you assess these patients should make a lot more sense. And then some of the lab tests you can do, provocative suppression, those are more specific to figuring out ways that the certain hormones are provoked or suppressed. So we look for certain things in the labs to see if we suppress this, then this hormone, we should get these results. And if we don't find those results, then that can kind of tell us if they have this pathology or not. We can get a urine, blood, or saliva sample as well, and then imaging, ultrasound, x-ray, CTs. Some of those are mostly to see if there's any type of tumors that can cause overgrowth of certain hormones. Okay, let's talk about the pituitary gland. Okay, remember what it does? It releases all these hormones. So a problem with hypopituitarism can be selective to one of these hormones, or it can be 2 or 3 or all of them. So it ranges. It all depends. Like, for example, one person could have hypopituitarism with their ACTH being decreased in its secretion. Another person can have the ACTH and the TSH, the thyroid, being decreased. So it can vary, really. It can be one, multiple, or all of them. And if it's all of them, that one's called panhypopituitarism. That's really rare, though. This can be caused by a disease in the hypothalamus, which causes diminished secretions in the hypothalamic, releasing hormones. And if that happens, then that means the pituitary gland is not going to get those hormones. Okay, that can also occur by a benign or malignant tumor. It can compress on that pituitary tissue, and it can impede it from releasing those hormones as well. Sometimes pituitary function can be impaired also by, let's say, like malnutrition, rapid loss of body fat, shock, severe hypotension, because remember, when you're hypotensive, the blood isn't flowing that well, and if the brain isn't getting that blood, then that means that the pituitary gland is not getting that blood, and then if your cells don't get that blood, what happens? Your cells die, and there's death, there's infarction, and if that happens, then that's no bueno. There's no more hormones being secreted, okay, because you lose those cells that secrete those hormones. So, head trauma, brain tumors, infections, you name it, radiation, AIDS, or sometimes the cause is unknown, and if that's the case, then it's called idiopathic hypopituitarism. So, dwarfism here is an example of a hypopituitarism that is selective of the growth hormone being impaired. And the way that this happens is that the growth hormone, that's responsible for tissue growth, right? So usually the growth hormone reduces, it helps the liver production of the somatomedins. That's a certain substance. But if the growth hormone is reduced, then that means there's reduced liver production of those substances. And if that happens, that means that the growth triggers are no longer happening in the body. And that means that bone cartilage is no longer being maintained. And if that happens, then your body isn't able to grow properly. And this alters the cellular regulation. And then that also increases the rate of bone destruction, leading to thinner bones and more osteoporosis. Okay, so that's an example of the hypopituitarism that is selective for the growth hormone, which is known as dwarfism. Okay, so that's one example, but there's many. Okay, so for hypopituitarism, if hypopituitarism means that you have decreased secretions of your pituitary hormones, what do you think hyperpituitarism means? It means that it's going to increase, right? So that means you're going to have more of those hormones acting on those glands. And like I said, this can happen to one and be selective of only one of these hormones, or it can be more than one, two, or all of these. And you're going to have a lot of the opposite issues. So here, we're going to focus on the growth hormone. So if hypopituitarism and selected to the growth hormone cause dwarfism, what do you think is going to happen when it's hyper? Okay, your patients are going to grow a lot, right? So in this case, hyperpituitarism that's selective for the growth hormone, an example of that is called acromegaly. If this happens, the growth hormone is oversecreted, usually after puberty, and these changes are irreversible. Usually the onset of acromegaly is insidious, and its progression is usually very slow. Usually the average interval from the onset of symptoms until diagnosis is approximately 12 years. Yeah, that's a long time. And once they diagnose the patient with acromegaly, whenever they do the CT scans, most patients, they have macroadenomas. So they have tumors that are about 10 millimeters or greater. So sometimes, like, they'll come to the hospital because they'll have like real severe headaches. Some, like 10% of them have visual symptoms, and then when they go get scanned, they see that there's like a tumor in that area, and then they'll have more signs and symptoms, but we'll review that on the next slide. Okay, a little bit more about acromegaly. Acromegaly, some of the symptoms you're going to see is an enlarged face, sometimes with a protruding chin, large hands, large feet, extremely tall, just like this lurch from Addams Family. A lot of bone thinning and bone cell overgrowth, and sometimes they have a hyperglycemia as well. Diagnosing patients with acromegaly, this can be done through suppression testing. Remember we talked about suppression testing, how sometimes we'll test to see if an agent will increase or decrease a certain hormone, and if we don't see the results we want, then usually it means that there's some type of issue with that hormone gland. Well, in this case, high blood sugar, it suppresses the growth hormone. So if you give glucose, then you would expect the growth hormone to decrease, right? So we're going to give these patients some sugar, some glucose, and after that, then we'll take the growth hormone level. If it doesn't go down, then that's a positive result for hyperpituitarism. Now, Treating these patients, non-surgical management includes drug therapy. These medications, some of them are dopamine agonists, and what they do is that they help inhibit the release of growth hormones. Emotional support is also important because this pathology, it really affects physical features of the body, and it can cause disturbed body image. So you really want to ensure that your patients are emotionally supported. Surgical management focuses on surgery to remove the tumor in the pituitary gland, and if you see in the picture here, they can go through the nose, which looks very painful. So we're going to look at patients that have adrenal gland issues. From our pathophysio, cortisol is a steroid hormone that is produced by the adrenal glands. In normal amounts, cortisol helps the body to respond to stressful stimulation, keeping the immune system in check. It also converts fat and carbs and proteins into energy for energy usage. And it also helps them to maintain our blood pressure and our overall cardiovascular function. So there are some benefits to having normal cortisol release. However, during times there can be an overproduction or over-secretion of cortisol. And if this happens, this will lead to some physical and mental changes to the patient. And an example of that is Cushing syndrome. Now, as a review, the adrenal glands are on top of the kidneys, hence their name adrenal. Ad is on top and renal is your kidney. So adrenal is on top of the kidneys. As we're looking at the glands that are on top of their kidneys, the adrenal glands, they are highly vascular, and we know that both the kidneys and the adrenal glands are highly vascular. So when we break down the adrenal gland, there are two areas. It is the cortex is one of them, which is about 90% of the gland, and the medulla is about 10% of the gland. And these glands are very small, but they have a large role in maintaining homeostasis. The cortex involves mineral corticoids, and our main mineral corticoid is aldosterone, and we've heard about aldosterone already. It helps you regulate sodium in water and also potassium. So at times aldosterone will help us to retain sodium and water, and by doing so it will excrete potassium. But when it's inhibited, it will do the opposite. It will cause us to excrete sodium and water, because wherever sodium goes, water follows. And when this happens, we retain potassium. So that mineral corticoid, aldosterone, will help us regulate sodium, water, and potassium. So that's how the concept of fluid and electrolytes comes into play. The cortex also is involved in glucocorticoids, and the main one here is cortisol. And we already talked about some of the benefits of cortisol. Also regulating the body's response to stress is cortisol, and the body's ability to maintain an adequate immune system. Also, it helps the body maintain blood pressure, as we said, and cardiovascular function. The third component here in the cortex are the androgens. They're the gonadocorticoids, and they're referred to as sex hormones. So the cortex has mineral corticoids, glucocorticoids, and gonadocorticoids. And the catecholamines in the adrenal medulla, the catecholamines are neurotransmitters that help with our sympathetic and parasympathetic nervous system. These catecholamines, they're epinephrine, norepinephrine, and dopamine. So those three, they help with the fight or flight response. So disorders of the adrenal gland, they usually involve over-release or under-release of, it can be either one or all of these hormones. The adrenal gland works in collaboration with the hypothalamus, remember, because the hypothalamus is the puppet master, right? So the hypothalamus has control over the anterior and posterior pituitary gland. And since that gland releases hormones that will target the adrenal gland, all three will work together in continuous communication. So that's a review of how the adrenal gland works with this whole hypothalamus and pituitary gland connection. There are times when the adrenal gland is unable to produce the corticosteroids as efficient as they should be. This is known as adrenal insufficiency. And an example of this is Addison's disease. This disease is a result of an autoimmune process that destroys the adrenal cortex. So with this, you see a loss of cortisol and aldosterone. And as we talked about cortisol, because there's not enough of it, there's going to be a decrease in gluconeogenesis. There's going to be less sugar in the body. There's going to be less muscle glycogen. This will also have hypoglycemia. And because of this, the patient is going to have a higher weight loss and anorexic. Because of low aldosterone, the patient will excrete a lot more sodium and water, and it will keep the potassium. It'll also cause the urea nitrogen levels to be higher in the body due to lower excretion. So this is an example of Addison's disease. So looking at the other end of the spectrum, when we have an overproduction of the hormones from the adrenal gland, we have what we call Cushing's syndrome. And Cushing's syndrome can be caused by either exogenous or endogenous factors. The most common cause of Cushing's syndrome is an exogenous factor. So exogenous means that it's there's an external stimulation from the outside of the body. And so this is usually found in patients that are taking cortisol-like medications such as prednisone. And these medications are used to treat a lot of inflammatory disorders, like for example, lupus. We also use them in asthma, COPD patients, and rheumatoid arthritis. We use them to suppress the immune system after the patient gets organ transplants as well. So we use them in a lot of rheumatology conditions such as fibromyalgia as well. So this type of Cushing's is usually temporary. It can go away after the patient has finished taking the cortisol-like medications. But sometimes the patients don't get off these meds, so then they have to take them lifelong. So then they live with these symptoms of Cushing's syndrome as a side effect because of the medication. Endogenous Cushing's syndrome is rare, and it usually comes on very slowly, and it can be difficult to diagnose, but it's usually caused by a problem with the adrenal gland. So endogenous, meaning it's inside, the internal is the problem. So this is why it's considered endogenous, because it's coming from internal. So it's a problem with the adrenal gland, or it can be the pituitary gland, which is located at the base of the brain. In the adrenal gland, the problem could be caused by a tumor. It could be cancerous or not. Tumors that grow will start to produce too much cortisol. And when the problem is in the pituitary gland, remember the pituitary gland releases ACTH. And ACTH is the hormone that communicates with the adrenal glands to make cortisol. So if we have a tumor in the pituitary gland that's secreting too much ACTH, then it's going to go ahead and tell the adrenal gland, like, hey, keep on producing more cortisol, and then too much cortisol is going to cause the symptoms of Cushing's syndrome. So symptoms of Cushing's syndrome are going to basically be symptoms that are present because of the oversecretion of the cortisol hormones, but they can also be symptoms from the oversecretion of aldosterone as well, and sex androgen hormones, because when there's too many cortisol hormones released, sometimes they overstimulate those other hormones. And the problem that we start to see in this patient is going to be from head to toe. So when we see the inappropriate metabolism of carbs, fats, and proteins because of too much cortisol, what we see is that the patient is going to have a lot of muscle wasting, a lot of adipose tissue, and especially a lot of obesity. And then they can develop these buffalo humps as well. They can also have very thin extremities. The adipose tissue starts growing unevenly in the body, so that's why you see like a heavy trunk area but a thin extremities stature. You will also see adipose tissue gathering in the areas like the back. And impaired cortisol can also lead to decreased immune system due to lymphocyte reduction. So patients will be more risk for infection. Impaired cortisol will also then impair wound healing as well and interfere with calcium storage too. So patients with Cushing's syndrome are going to be at risk for bone fractures and osteoporosis because of that calcium interference. Cortisol being impaired can also cause patients to be emotionally labile. They can be depressed and have mood swings. So too many androgens being released can really interfere with the sex drive and the libido. It can also cause facial hair development, acne, red cheeks, flushing, impaired menses. Impaired aldosterone, as we said before, it can lead to too much sodium being retained, too much water being retained. So they're going to retain a lot of water. This is going to increase the blood pressure. This can cause a lot of edema in the face. And patients will start complaining that they have a recent weight gain and that their blood pressure is rising for no reason. It can also interfere with the integrity of the capillaries, causing some premature capillary bursting. And you're going to see this in the stomach with the with the purple striae, because it's stretching and it's also exposing all the veins. Impaired cortisol will also lead to high blood sugars as well. So patients will start having signs of diabetes. So they're going to have the 3 Ps: polydipsia, polyphagia, and polyuria. The skin will further be affected by having fragile skin. It can bruise easily. And then as the aldosterone, as it's released, and as the sodium water is retained, the body will also get potassium. So it's a lot of things. So that's also going to lead to electrolyte disturbances. So you're going to get hypokalemia as well. So looking at the diagnosis of Cushing's syndrome, most of Cushing's syndrome is going to be diagnosed because of the history and the physical and the assessment. You're going to see a lot of signs and symptoms. So you have to know the patient's history, ask them questions about their medications. Are they taking steroids? Because it's going to give you a lot of clues as to if they have this or not. And then because of the physical assessments are so predominant in Cushing's syndrome, most clinicians are able to make a pretty affirmative diagnosis just by the presentation itself. There can also be signs and symptoms of high blood sugar, like we said, like the 3 Ps. The patients could be complaining of fatigue or tiredness, sometimes like bone pain or muscle weakness, especially if they have osteoporosis. Typically, the doctor will order, to diagnose this, they're going to order like a salivary cortisol level, as well as a urine sample to test for cortisol deposits in the urine. Salivary and urine cortisol levels will usually be increased in Cushing's syndrome. Many times the Cushing's syndrome, when it's due to tumor, they can do X-rays, CTs, and MRIs to look for the tumor if it's in the pituitary or the adrenal gland. And if there are tumors involved, then the best medical management choice would be to have the tumors removed. So it might be removal of the adrenal gland itself, or part of the pituitary if the tumor is there. So if the symptoms are not due to tumors, and they are due to the exogenous use of corticosteroids, and the patient will be maintained on the steroids, then your nursing plan must be to focus around assessing and treating the potential complications involving the overstimulation of cortisol, aldosterone, and the sex androgens. Because this condition affects a lot of different areas, there's going to be a multitude of nursing priorities and a lot of education that needs to be done for the patient and the family. So we will be centered around priority problems, and the first one is a risk for injury. So risk for injury is based on the presentation of the patient. We usually deal with risk for injury related to weakness because, as we said before, too much cortisol disrupts the calcium deposits into the bone. So now they're at risk for osteoporosis. So we want to make sure that we are preventing any musculoskeletal complications. Our other diagnosis would be risk for infection because now we have altered protein metabolism and decreased inflammatory response. Another nursing diagnosis is skin integrity related to edema, thin and fragile skin, and also impaired healing of the skin and the wounds. Another diagnosis could be self-care deficit relating to fatigue, muscle wasting. So these patients are probably not going to be as energetic to take care of themselves or provide their self-care. Another diagnosis is excessive fluid volume due to the retention of sodium and water from the increased aldosterone. You could also have electrolyte imbalance because now you have a risk for hypokalemia. Looking at psychosocial nursing diagnoses, we want to address disturbed body image related to physical appearance alteration, impaired sexual functioning, and decreased activity levels. We also want to center our care around disturbed thought process related to the labile mood swings, the irritability, and the possibility of depression. We want to provide a protective environment because we want to protect the patient from falls, especially if there's a risk for injury. Excuse me. We also want to assess their range of motion, their strength, their ability to do their ADLs independently. We want to provide assistance to the patient who is weak, and prevent them from colliding into other structures or furniture. We also want to make sure that if the patient is in the acute care setting, that the patient is calling for help, they have their collar next to them. We want to make sure that they do not have to reach for any objects because patients falling out of bed due to reaching is one of the leading causes of falls and injuries in the hospitals. We also want to recommend foods that are high in protein, calcium, and vitamin D. This will help to minimize any muscle wasting and osteoporosis. So for this, we really do have to collaborate with the dietitians in order to have a special diet that can give them the meals that they need. We also want to teach the patients that they have a high risk for infection, so therefore they need to practice good hand hygiene, and simple daily hygiene is very important in order to reduce risk of infection. These patients should avoid unnecessary exposure to people with infections and wear masks. Patients with Cushing's syndrome also need to make sure that their vaccinations are up to date, to report any low-grade fevers, any coughs, any urinary symptoms that are abnormal, Anything that's out of the ordinary that could be a sign of infection should be reported, because also the skin is our largest organ and one of our primary defenses against infection. So they also need to do skin assessments for that as well. They need to really make sure to let us know if there's any sign of infection, because this Cushing's syndrome, since the cortisol is so high, the immune system is not working as it should, so it can mask the symptoms of infection. Patients that are challenged with mobility need to be provided with assistance, changing positions frequently, training them Q2, especially if they have signs of fluid volume overload. You need to assess their eyes and nose, daily weights, and electrolyte imbalance. And if they have too much volume overload and have edema, then this is also be a potential cause for skin injuries. So they really need to turn every 2 hours to prevent those skin injuries. And if they also have the electrolyte imbalance and fluid overload, then you need to do a vigilant cardiopulmonary assessment, especially if there's a new onset of heart failure. Assess if there's any crackles in the lung. It might show pulmonary edema. Vital signs need to be monitored frequently, especially the pulse and the blood pressure, and the respiratory rate as well. Monitor for any sign of fluid retention. So patients should be weighed at the same time every day, with the same scale, in the same clothes. Weights need to be very accurate, and remember that for every 1 or 2 pounds gained in 24 hours is pretty significant, and it's a really huge sign of fluid overload. In order to reduce the edema, patients will often be placed in fluid and sodium restrictions. So we want to make sure that our patients are adequately educated on those foods to avoid sodium, because too much sodium is going to cause more fluid retention. So teach them to avoid frozen foods, processed meats and foods. We want to encourage moderate activity to prevent complications of immobility. Plan rest periods throughout the day. Make sure that they promote some relaxation and quiet time as well. Also educate your patients and the family that sometimes that they're going to be emotionally unstable. They're going to have mood swings. They're going to be irritable and depressed, because those are going to be side effects of the medication, or if it's an exogenous reason for the Cushing syndrome. But any psychotic behavior should be reported to the healthcare professional immediately. Patients should be also taught how to check their blood sugars and how to monitor their glucose levels, and to monitor for signs and symptoms of hyperglycemia, the 3 Ps, remember? They should also be taught the symptoms of hypokalemia. We learned that in fluid and electrolytes. So that way they can report any of these symptoms that would be concerning if their potassium is falling. So treatment of Cushing's syndrome related to the adrenal tumors may mean that the patient would have to undergo the adrenalectomy. So adrenal is the gland, and ectomy is removed, so remove the adrenal gland. If the adrenal gland is removed, the patients may go home or will stay at home on a lifetime of corticosteroid replacement, because since there's no more adrenal gland to make that steroid, then they're going to have to take it with the medication. They will need to be taught the importance of taking their steroids at the same time every day as scheduled, not to stop their steroids at any time, not even for a day or two, when the patient's body is accustomed to receiving steroids exogenously. Then the adrenal gland is going to become suppressed. So even if you have a functional adrenal gland, the adrenal gland becomes suppressed when there's the exogenous medications like steroid being given to the patient. So if you suddenly stop your corticosteroid medication,
The adrenal gland is kind of taking a nap and kind of taking a vacation because it's kind of gotten used to the external medication working for the body. So if the corticosteroid medication is stopped, the adrenal gland it's going to take a while for it to start working, start to functioning. So it's going to take a while to start to produce any extra cortisol, aldosterone, or androgens. And since the body is not going to have any of those, then this is going to cause, as what we know as an adrenal crisis, which will go in the next slide. So this can be a side effect of adrenalectomy without steroid replacement. This can also be an effect of patients who are taking corticosteroids who do not taper off the steroids and just suddenly stop the steroid use altogether. So we really want to teach our patients to make sure to take their steroids as prescribed. Do not miss them. Do not stop them at any time. That they need to be tapered down. So if there's a sudden stop of cortisol, a sudden drop or absence of it, then this is going to manifest into what we call Addisonian's crisis, also known as adrenal crisis. This will lead to ineffective stomach digestion and will also affect the liver by decreasing the hepatic glucose release. This will also cause vomiting, diarrhea, and dehydration. So this is going to lead to hypovolemia, hypotension, shock, and death. We can also have major electrolyte imbalances with Addisonian crisis due to the loss of aldosterone, because as we mentioned, this is going to cause sodium and water to fall, leading to immediate loss of water and sodium in the urine, which is another reason why the patient becomes hypovolemic and hypotensive. This will also further advance shock and potential of death for the patient. So when the kidneys are wasting the water and the sodium, they will also retain potassium. Remember, too much potassium in the body can lead to hyperkalemia and arrhythmias, lethal arrhythmias involving the ventricles, also known as PVCs, turning into VTAC or VFib, ventricular fibrillation. So this can lead to death. So in order to avoid all of this, patients who are taking exogenous corticosteroids should always be taught to take their steroids, like I said, on the same time every day. Don't miss a dose. If they do need to come off the steroids for any reason, then remember, we're going to taper them off. The doctor will taper the patient off the steroids by reducing the frequency or the dose. So this is going to allow the adrenal glands to kind of start waking up slowly and perform their functions independently, become unsuppressed, while there's still some steroids being fed into the body. So this can this won't happen if the patient has undergone an adrenalectomy and no longer has an adrenal gland, of course. But and patients who have developed Cushing's syndrome due to intake of corticosteroids, say for like asthma or lupus, and the doctor feels that they might want to give the patient a break and taper off the steroids to reduce the Cushing's syndrome effect, then they're going to need to allow the patient's adrenal glands to start waking up again and start producing those hormones. So that's when they would be tapering off the patient off the steroids and not abruptly stopping them.